Our next presentation is Dr. Sai Dileep. His topic is interlaminar endoscopic technique.
Good afternoon, friends. It's a tough time for you to have a postprandial session on interlaminar endoscopic technique. Just my topic is just to revising the basics of endoscopic spine surgery and little about the indications which are going over the horizon, where transforaminal surgery was definitive indication. We are trying to reach it as a definitive indication using PSLD. So as you know, there was a nomenclature by the AO Spine for endoscopic surgery. It is a great initiative now, and slowly endoscopic spine surgery is acceptable by the World Spine Society, NAS and everywhere. So initially all endoscopic surgeries, the basic nomenclature is full endoscopic discectomies, full endoscopic thoracic discectomies, full endoscopic lumbar discectomies, and posterior endoscopic cervical decompressions, posterior endoscopic cervical laminoforaminectomies, then lateral recess decompression. Now it has gone to the stage of stenoscopic fusion, stenoscopic ACDF, and stenoscopic jumping fusion techniques. So the evolution of the endoscopic surgery has been mainly because of instrumentation. So we should give big kudos for the new invention by the great teachers. So our forefathers of endoscopic spine surgery has fought for to create new instrumentation. So the journey was just interlaminar endoscopic lumbar discectomy by Professor Rutten. It's slowly gone over to endoscopic lateral recess decompression. So with the invention of the drill bit and all the stuff and the punches and the instrumentation, it has gone to unilateral laminotomy and bilateral decompression. Now it has gone to contralateral endoscopic lumbar foraminotomy, which is my topic, and also fusion. So the evolution is because of the instrumentation, as I was saying. So initially the instrumentation was just a forceps and a small annulus cutter, where they was doing something called ligamentum flavum splitting or cutting technique for a wide laminar windows like L5S1, where transforaminal approach, which was the first generation endoscopic spine surgery, the iliac crest was a big issue. Then the second generation instrumentation was because of the endoscopic burr, the Carrison punches, and slowly the third generation is because of the bigger size of the punches, bigger instrumentation, and of course good way of dealing with the bleed. So initial indications for basic interlaminar technique was just subarticular herniations of L4, L5 and L5S1, and lateral recess stenosis, and foraminal and central stenosis has been now the present indication. The spinal instability was a contraindication, where the severe scoliosis, you expect the anatomy to be disturbed, which you need to see. Now even those kind of cases have been taken up with endoscopic spine surgery with the help of navigation. Previous posterior surgery definitely is a tough indication, where differentiation of the anatomy is disturbed, still where transforaminal surgery plays a very important aspect. And higher lumbar levels was also initially a tough job, because facet knockoff and transforaminal surgeries were safer for higher thoracic disc surgeries. But myelopathy and ossified ligamentum flavum, I think now in PSLD is very good. Even for disc herniations in thoracic surgery, we do something called facet knockoff surgery, facet undermining surgery, where you don't touch the central dura, which is kind of a modified transcambrian approach or a modified transforaminal approach. So these were the basic instrumentations how the PSLD can be done. So initial players, we were trying a lot of instrumentation, we wasted a lot of money. But now the newer generation, the advantage of endoscopic surgery with PSLD scope is the instrumentation is less compared to transforaminal surgery. It is just 2 or 3 punches, 1 dilator and 2 or 3 forceps, and an annulus cutter or a disc forceps, and a nerve retractor and a sleeve. Burr and RF cautery, which is mandatory. So the technique, this is the OT setup, how you going to present and how you going to start. This initially for beginners, the side of herniation is the side of the surgeon's hand, and all the visions, C-arm, X-ray and the image processors, everything to the opposite side. Your scrub nurse stays to the right side or left side depending on the hand of your surgery. This is very important, and this is also important when you're trying to do something called contralateral approach. So this pic has been already shown by one of my close friends, and I think you can see a pic where you do a straight interlaminar decompression, and you see a D picture where you are trying to do a contralateral decompression. So just you do unilateral laminectomy and just tilt the scope, you can see the opposite foramen. This is one of my Bible for my endoscopic spine surgery. It was drawn by my professor Dr. Lim. So whenever I go for a surgery, what kind of approach doesn't matter. This pic is my Bible. So if it's stenosis, I start with the high spinolaminar junction, do high cranial laminotomy, then do flavectomy. And depending upon the lateral recess and amount of disc herniation, I go for the next part is the caudal laminectomy and the facetal depending on the lateral recess. So this is the first 1, 2, 3, 4 steps, the orientation of the traversing and the exiting route. So if you know this picture, half of your job for any kind of endoscopic surgery is going to be easy. Even for doing contralateral approach, the process is same. You start with the high cranial laminotomy, go and remove the foraminal below spinous process ligaments, do contralateral laminotomy and flavectomy, and you can reach the opposite side. So similarly for doing stenosis, you start with high cranial laminotomy, see the edge of the flavum which is attached to the cranial lamina, start splitting it until catch it up and just like you open surgery, pull it down until where you want to do it. So it's going to be easy. So it's a big trouble while you're doing interlaminar technique using the rivoscope. People were doing flaval just splitting of flavum or cutting of the flavum. So what happens, the cranial flavum and the caudal flavum are just fragile and they're just floating around. So you tend to waste lot of time taking out small pieces of flavum which is really disturbing your vision, but they do or do not give compression. So high cranial laminotomy will solve the purpose of endoscopic decompression to be more faster. This is one more picture which you know from the basic. So this is how the traversing route and how the exiting route will be there for orientation. The previous picture and this picture will solve the purpose of most of the spine cases. When you are doing any kind of interlaminar technique, whether it's biportal surgery or a uniportal surgery. Of course, position is very much important. I prefer using a Wilson frame. Wilson frame, there is sometimes you unnecessarily remove some amount of cranial lamina or bone which you don't require to do. So good Wilson frame will give good distraction of the laminar window. So sometimes you don't need to do unnecessary bone work. Surgical technique, it depends. My place, I prefer doing it under general anesthesia. Patient is on Jackson or Wilson frame. So sometimes it really doesn't matter, but you see the spinous process are not overlapped. Just a rostrocaudal angulation of 10 to 15 degrees for the lower lumbar levels like L4 and L5S1, so that the orientational CR is exact. The spinous process doesn't come in the middle of the laminar window. So just a caudal tilt of 10 to 15 degrees will decrease your bone resection, decrease your flaval resection. So you don't tend to see spinous process in the middle, which is not really seen, but because of the image intensifier, it looks like that. These are all small surgical tips to increase your speed of your surgery. And this is one more technique. When you are trying to put a dilator into the space, sometimes you just end on kinking on the cranial lamina. Just if you feel the stenosis is more, just a lift on the head side with the surgical table or something like that will orient the spine laminar in the very straight line. So this will help us to do little amount of bone resection or little amount of surgery. These small pearls of surgery is very helpful when you start your surgery. The technique is same. Dr. Lim is going to talk about it. Though you start with surgical technique starts with the spinolaminar junction identification. So according to me, any good bony landmark is a good identifying point to start your surgery. So it can be a spinolaminar junction or a facet. As Dr. Akrov has told, PSLD is just a joystick in the spine. You start with one bone and you can reach wherever you want. So these are the names of the points which have been discussed as Kim's point, Wu's point, where Wu's point and Kim's point are very useful to know how much you want to remove the SAP for the fusion for doing endo-T-leaf. So after you see the flavum, you do it's for only interlaminar technique. You want to do a lateral recess or lateral disc, you just go do little amount of facetectomy with a drill or a punch. Then enter the epidural space using a Carrison punch or annulus cutter to open the flavum. And resection of the disc, just use the scope or a nerve dilator, nerve retractor to push out the neural elements and do the discectomy. So mutilation of the disc elements can be done with there is something called nerve retractor, or you can use, if you are using a smaller scope like Revo, you can use the same sleeve. So of course, extraction of the disc is the surgeon's most highest satisfaction which is possible with this. Don't see about the sister who is watching me. So this is a small thing, percutaneous endoscopic transforaminal lumbar foraminotomy. I want to discuss about it, but one of my friends were talking about it. My gut feeling, because my journey of spine surgery has started from transforaminal surgery to stenosis. When you're doing foraminotomy during transforaminal approach, it is more of ventral facetectomy. Ventral facetectomy, the chance of the facet to be destroyed is almost 60 to 70% compared to the ipsilateral facetal resection. So when you're trying to do foraminotomy while using transforaminal approach, you try to do something called ventral facetectomy. So the chance of the patient going to listhis is quite high. The advantage of doing endoscopic interlaminar lumbar foraminotomy is, if you can do, I'll be showing in the next slide, you can do something called contralateral approach, where you enter the foramen, you undermine the facet. So you're undermining the facet is just decreasing the thickness of the facet. So your chance of destroying the facetal is quite narrow. So my gut feeling after my transition from interlaminar to transforaminal to interlaminar journey, I feel interlaminar contralateral decompression for foraminal stenosis patients are quite comfortable. Even transforaminal, it's comfortable, but if I do ventral facetectomy I don't know how much I do. So if I want to do in transforaminal in the previous stages, I would have done a fusion using transcampus fusion. Complications are same: dural tears, intraoperative bleeding, postoperative hematomas. Bony bleed is the most common trouble, and I follow my master's technique. I use something called cuckoo technique. Just use your Carrison punch. Since it's a cancellous bone, just press the punch towards the bone. Half of your bone bleed chances come down. Even bone wax can be used. Of course, any endoscopic surgery, you feel you have removed so much, but sometimes they end up with reherniation, which is far more bigger than the normal. Scope, yeah, the future is, which sir is going to discuss, PSLD, T-leaf, ACDF, thoracic decompression. The initial limitations for endoscopic surgery was very much poor. Now you can see almost 97.36% of spine surgeries, spine ailments can be dealt with endoscopic spine surgery. This is just my drain if I do these things. So I just check the intraoperative epidural drain. Chance of epidural hematoma is quite less if you put a drain. These are the steps what we do. We start landing on the lamina, remove the soft tissue, drill the sublaminar approach, do the laminotomy, then remove the yellow phlegm, detach the phlegm. Step 4 is separate the neural elements and retract and do your discectomy. So these are few cases which I have done: cervical, posterior cervical, para-PSLD, cervical surgeries, redo surgeries, stenosis, where patients walk immediately post-operative, just within 1 hour after the surgery. Probably my language is different, you don't know. The patient is telling he has no pain, and I'm asking him again, he's getting angry. Why you want pain? No, I said, I was very conscious, because after shifting from open surgery to endospine surgery, patient saying immediate pain relief is a happiness for the surgeon. So these are different kinds of epidural lipodermosis causing fat causing obstruction and S1 radiculopathy. And I can show you a drill how we used to do laminotomy, discectomy. And there are few things like where we do posterior laminar, I think you can see this. A failed back surgery which has been previous laminectomy has been done probably 6-7 years back, and we try to resect it. So I want to finish off with something called foraminal for something called paraspinal surgery or para-PSLD or para-UBE is an approach. This is one of my favorite cartoon. It says that outpatient spinal surgery it was a myth 10 years back. So I have seen Dr. Putowski operating transforaminal surgery under local. So the patient's girlfriend calls him and says, "Sure, and I'll be home for dinner." I'll ask the doctor to hurry it up. So endoscopic surgery has changed the fear factor in the patients. So I just want to talk percutaneous stenoscopic lumbar decompression with paramedian approach for foraminal and extraforaminal lesions. So this is a very big indication, because initially transforaminal surgery was the ideal technique for doing foraminal, and still the ideal technique for doing foraminal or extraforaminal surgeries. Because foraminal lesions, if it's too below the facet, you need to knock off the facet. If it is compressing the exiting route, it's not easy to go and decompress it. So definitely transforaminal approach was good. Since we are the followers of a great surgeon who is advocating a new type of surgery, we try to overcome this trouble. So by starting a new technique called para-PSLD. It was first performed by Dr. Lim. These videos or photographs are of Dr. Lim, which he has published. It was same like the normal PSLD, the preparation, the scope and all similar. The instruments were similar. So the procedure was just, I think even Dr. Akraway showed you about the foraminal stenosis which he has done. So the skin incision was, the docking was 7 mm, just parallel to the lateral to the midline. Shows the midline and the pedicular lateral line, and just 3 to 4 centimeters out of the mid pedicular line is good enough. So this is a good diagram, the difference between transforaminal surgery and where we tend to dock on the isthmus and SAP. But here we don't dock on the SAP. So if you want to do foraminal decompression, still you are parallel to the stenoscope is parallel to the nerve root. So the chance of you injuring is comparatively less. So transforaminal preparation for peritoneal decompression with the paramedic approach is more advantageous if there is concomitant stenosis. If it is a fresh disc herniation, still I advocate doing transforaminal approach, but it is possible using para-PSLD. So the procedure is same. You just check the AP. It is quite oblique. I think you can see Dr. Lim doing it. So he does it and he goes to the, he starts going from the parallel, and you can see there is a decompression. So you can see that he has entered through the para-PSLD and entered on the ventral facet of the SAP. Try to decompress the facet through, make an incision over the isthmus and the transverse process. Just resect it through the pars, make a small hole and remove the foraminal ligaments, see the exiting route and just decompress it. You can do discectomy and also decompression. So this is what you can see: the isthmus, the cephalate, the foramen. The isthmus is removed, the root is seen, and also the thecal sac is also visible. So these are the various foraminal stenosis which our patients have under post-surgery who has undergone para-PSLD. These are the foraminal structures. Rarely you tend to have foraminal arteries, which is definitely a bleeder issue, but these are more common in the higher levels, but not much common in the lower levels.